Hello, everybody. Good evening. Thank you guys for coming. I love these. I think it's great. It's a rapid fire update and kind of looking at all of lung cancer as a spectrum. So it's great. And I love being a part of it. Thank you. Lung cancer screening is my part, which I love. Most of you that have met me know that I really like talking about it. I'm very passionate. I think it's an important discussion to have. Again, I'm here in Mehta. I work at UNC Rex Pulmonary. So I'm gonna go over some of the old literature. There's not been a lot of updates since last year, but I like going over the couple of studies that really you should understand when you're talking about lung cancer screening. We'll review the guidelines for anybody who's not familiar with it. It has changed over the recent years, so I want to make sure everybody knows the new guidelines and are practicing the updated guideline recommendations. And then I just want to talk about a little bit of a different perspective from lung cancer, and I'll go over some of the studies and why that's important. So, you can't talk about lung cancer screening unless you know the scope of the problem. Many of you have seen presentations on lung cancer screening. You've probably seen this slide itself because it's so alarming. I think most of us will put it on there to just show you the sheer number of deaths from lung cancer and how it exceeds any other cancer. For men, more than colon, prostate, pancreas. There's more lung cancer deaths than any of those three combined. For women, there's more lung cancer deaths than any female reproductive organ cancer combined. So it's a big problem, and I think it's very important that we have these discussions here. I do this every year. We would look at where do everybody think we are in terms of screening in North Carolina. I'll skip it because I think we're going quite fast today, but a lot of times I want to see where people think we are in terms of screening for lung cancer screening. And as of the most updated 2022, some of this data takes longer to get updated. We are at 8.1% as a state. That's up from 6% in 2020. So we're moving in the right direction. That's higher than national average, which is 5.8%, and that's up from 4.2%. So we're gradually moving up, but to show you how much more we have to go is this. So how are we doing relative to other cancer screenings? And you can tell we're all the way down here, and it's not great. Now, you can also tell we're in our early stages. A lot of those lung cancer screenings, a lot of those cancer screenings were dating back to 80s, right? So we have some time to go, but we haven't moved the needle very much in the time that we've had these updated recommendations. So we have a lot of work to do in more than just screening. And, I put this slide here so everybody gets a bit of a perspective. In North Carolina, we all work in North Carolina. All the speakers are from this area. So how are we doing in terms of just grading ourselves in cancer care, right? So we rank 40th in terms of new cases. So we're below average in terms of nationwide, in terms of identifying new lung cancer. We're slightly below average in 5-year survival in North Carolina. We're at the national average when it comes to early diagnosis of lung cancer, so identifying cancer in the early stages. We're at the national average there. We're again below national average when it comes to offering surgical treatment options, and again below national average when it comes to not offering treatment at all, or patients not receiving treatment at all. So we have a lot of work to do as a state as well, and that's why it's important to have these discussions. We really have the whole spectrum of cancer care. We can do better. So quick review of the data and the literature based on lung cancer screening. Where did it come from? The history of it. I don't want to spend too much time on that. We've done that last year even. But, lung cancer screening idea is not new. It's been there for many years, dating back to the 60s, when they used to try to use chest x-rays and sputum samples. And I always mention this because I still, to this day, have providers order a sputum sample for cytology for cancer. screenings, and it's outdated and it didn't work. There was no actual benefit noted with chest x-rays or sputum samples. So there was never a unified screening for lung cancer. It wasn't really into the refinement of CT scanners that even the concept of using a CT scanner to screen patients came about, right? And it was that low dose helical scanner that came up that said, well, look, you can scan patients for a fraction of the radiation, a tenth of the radiation. You can see here. Now it obscures the surrounding tissue, vasculature, organs, all of that, but it gives us what we need to see. You could see this small right upper lobe pulmonary nodule that's identified on a routine high dose radiation scan, and it looks exactly the same on the low dose scan. So they realized that using these CT scanners, fraction of the radiation, can be helpful. So that's when all the studies started coming out trying to use low dose CT scanners for screening. They were all underpowered, never showed any actual mortality benefit. It wasn't until two more recent trials, the NLST trial and the Nelson trial, that we were able to show significant mortality benefit, right? So quick review, NLST trial was the first trial. It was done in the US. Multiple medical centers were involved in this. It was one of the largest trials of its kind, 53,000 individuals, age ranging from 55 to 74. That's an important number to remember because that's how we started forming our guidelines, right? 30-pack years smoking history and an active smoker or had quit within 15 years would enroll in this trial. They basically split the group into you'll either get a low dose CT scan or you'll get a chest x-ray. And they were able to show significant fewer lung cancer deaths from the screening CT scan rather than the chest x-ray because they were able to find cancer earlier, detect it, treat it. And so they were able to show a significant dynamic shift, 20% reduction in mortality in the CT arm. All-cause mortality reduction of 6.7% in the CT arm. What does that mean? Well, a lot of times with screening CTs, we want to know the number needed to screen to save one cancer death, right? So for lung cancer, that's 320. That means you'd have to scan 320 patients for one cancer death save. In perspective, for mammograms, it's 900 to 1,900 patients being screened, or colonoscopies 500. So to save one death, you have to screen less patients, even with lung cancer. The second big trial was the Nelson trial. This is a very similar trial. This was a European study that looked at around 15,000 patients, a little younger, 50 to 74. Again, the age matters because that shapes our guidelines, right? So 50 to 74. And they basically said, either you'll get a CT scan or we'll let you do what you normally do, whether it's a chest x-ray, sputum. So they really didn't control that arm of it, right? And so they looked at the differences there. And significant differences there too. At 10 years, they were able to show in males a significant relative reduction of 26%, and in females, even slightly higher, 39% relative reduction. So their highlights from their study, which was landmark, right? The first study, NLST, showed a 20% reduction in mortality using lung cancer screening CTs. And here with Nelson, they were able to show a 26% reduction in mortality. Some of the other great highlights out of Nelson trial was the people who are screened, 70%, close to 70% were found in early stage lung cancer, right? Most of the times we talk about early stage. Why is it important? Because that's when you have the best prognosis. You want to find it early, treat it, surgical options, and you have the best chance of prognosis. And that's why some of these were almost important. And then they highlighted the difference between mortality benefit from screening with men and women. And women did show a significant benefit from screening. So again, does anyone know the current guidelines? You know, if you had to pick one, you know, the trick here is that in 2013, the guidelines were 55 to 80%. That has now changed. They have lowered the age category down to 50%, or age of 50 to 80. and a minimum pack year of 20, down from 30. So before 2021, the correct answer would have been A, and it's now correct answer is D. So they did end up changing it from 2013 to 2021. So just remembering, basically the new guidelines are age 50, 77 with CMS, 80 with a US task force. Current smoker or quit within 15 years, and then 20 pack year smoking history. And remember, we calculate that by taking how many packs a day you smoke and multiplying it by the number of years. It gives you 20 pack year smoking or greater, right? So why did they change it? Why did we change the dynamic here for screening? Well, it was mostly because they went back, looked at all the data. Some of the remarks I made with Nelson trial, it was a younger group. Women were being identified significantly younger. So it was really the African-American population and women that we were noting that we were missing with the older guidelines, that with the newer guidelines noted to encompass them more, right? And so that's why they changed the guidelines now. So the kind of the update, what's new, what's changed in lung cancer screening? That was all the old stuff, what's now the new stuff? This is a pretty interesting dynamic shift here. I'm going to bring up, it's called the TALENT study. This was a Taiwan lung cancer screening trial, but this was the first of it, one of the first of its kinds where it looked at non-smokers, right? We talked about all of the previous studies that we talked about were smokers looking for lung cancer screening. This was the first trial that looked at non-smokers age 55 to 75 with certain risk factors as they listed down here. And then they looked at doing a CT scan or a low dose CT scan based on history and chest x-rays, right? And they biopsied them, and they were able to show a significant incidence of lung cancer were found in non-smokers that were exposed. So non-smokers with secondhand exposure or chronic lung disease such as COPD. So what did they find when they looked at people who didn't smoke but had high risk from others smoking or environmental exposures, which, interesting enough, this is one of the big questions I get a lot of times from patients or spouses who's like, I don't smoke, but my spouse smokes all the time. Should I be screened? That's why this is an important trial to talk about. So interesting enough, they were able to show a high incidence. They picked up 2.6% incidence of lung cancer. Put that in perspective, the first trial that I talked about, NLST, their lung cancer incidence was 1.1%. Nelson's incidence was 0.9%. So this is in non-smokers with just the right number of risk factors, and they were able to find a high incidence of lung cancer in these patients. If you look at the red in the chart in the bottom, you see most of them found early and treated, right? Again, early diagnosis and treatment is your best chance of prognosis. So this in itself was a very interesting trial. So that was done in Asia. This one was done in US. They took what they learned from the TALENT study. They kind of extrapolated some more information. This study, it was a multi-center study that looked at about 1,000 Asian females. It's called FANS study. They basically excluded anybody that's had a history of lung cancer or so, but they just took the age group. If you look at it, interesting enough, pretty young population, 40 to 74, female, non-smokers. And they put them in a medical discussion. They looked at shared decision-making and said, well, let's either screen them with a CT scan and some plasma-based DNA as well. I don't want to hound on the study itself, but interesting enough, their incidence rate was 1.5%. Again, and I put the other trials' incidence rates up there as well. Interesting, they all underwent resection because they were early stage diagnosis, all EGFR positive mutations, and were treated with Tagrisso. So my bottom line from this, no, it's not a large randomized trial. It's only 1,000 patients. It was multi-center perspective. It may not impact our current demographic. This was a subset of a population, But what it does highlight is that we've always talked about screening in smokers, but a lot of us as providers get a lot of questions from family members or people with high risk environments. Should I be screened? So this brings up just a bigger question and a bigger discussion regarding looking at non-smokers. We focused a lot of energy on screening smokers, but should we be looking at non-smokers? And I think these two past screening trials are really going to trigger a bunch of new studies looking at this. And again, 20% of lung cancer deaths is from non-smokers, largely attributed to radon gas. Just for you to know, 13.5% of homes in North Carolina are above the level they should be. Other risk factors, including secondhand exposure, asbestos, environmental exposures, all related to non-smokers getting lung cancer, right? I always put in a little reimbursement information for anybody who's ordering lung cancer screening. What types of reimbursement codings do you need to know? These are it. I put them up on the slide. I think I'm running out of time, so I'm gonna not go through the myths, but really the gist is even if you quit smoking, remember 15 years out from smoking, lung cancer screening is no longer a myth. It is standard of care. Yes, you can have there are false positives with lung cancer screening, but when you go back and look at the studies, very small percentages, less than 1% typically went on to have any type of a procedure related to a false positive. Again, that's the guidelines, just as a refresher. And that's it for me. Thank you, guys. Hopefully you got something out of that.
Thank you so much, Dr. Mehta. We really appreciate the presentation. And if you have questions for Dr. Mehta, feel free to drop those in the Q&A either now, or you can save those at our peer discussion. So if you have questions throughout any of the presentations, feel free to go ahead and put them in the Q&A, and we'll be able to discuss all those with Dr. Ruiz at the peer exchange. And with that, it is my pleasure to now turn it over to Dr. Shelton.
Hey, thanks. Thanks, Paige. And thanks, Dr. Mehta. I was tasked with updating the use or basically the indications and uses of radiation oncology in lung cancer. And a lot like Dr. Mehta, I would say not a lot has changed in the last year or so. So I'm going to kind of provide a different perspective and look at how small community radiation oncology has evolved for us. So these are my disclosures. I do have a grant from the LCI looking at ways to increase awareness about geographic related disparity. And we are a rural cancer center, a very small rural cancer center that does not provide all cancer services, which may not typify the other speakers' geographies. So my goals today over the next 15 minutes are to do three things. One is to highlight what is prevalent in a community radiation oncology practice in rural North Carolina, specifically for lung cancer. I want to also show where I think we're doing better for this disease as community providers of radiation oncology. And last, I would like to discuss where I think we can do better through community academic networks and through collaboration. And one example I'm going to give is the Breaking Barriers Collaborative. So this is a great picture. This is where I live. And as you can see, access can be a challenge rurally. And lung cancer, I think, is the perfect cancer to highlight these concerns. This shows how small we are as a providing geography and how barriers to care can exist really geographically. Notice there was no hospital here 20 years ago. And in fact, we really didn't have radiotherapy until shortly after that. So this is kind of a new thing for us regionally in a very small rural geographic location. So our county data really typified this access concern when looking at lung cancer. So cancer in our county was the #1 cause of death at baseline, 30% in our county versus 22.7% in the rest of North Carolina when we built our small community hospital. Lung cancer, of course, was the #1 cause of cancer mortality, and we were about 25% higher in relative lung cancer mortality at baseline than the rest of the state. So we, in fact, were in the top 6 worst counties in the state in terms of cancer mortality for this disease. And part of that, I think, was based on the fact that really no coordinated care existed locally. We didn't have a hospital. We didn't have radiology centralized. We had no pulmonology services, et cetera, et cetera. So as you can imagine, there were a lot of barriers to care, which were commonplace and probably provided some impetus for those bad outcomes. So this is an interesting map that looks at our state from the perspective of a rural versus urban geography. And we've had some urbanization of our state over the last 20 years. So I'm going to just kind of briefly outline a couple of facts here. One is North Carolina, surprisingly, is the #2 state in the country for a rural population at 3.5 million people who live in rural counties. This map, when you basically look at cancer mortalities by geography, shows, I think, a very astounding fact. 80% of outliers for lung cancer mortality occur in rural geographies. And these are data that are normalized for each county to the population. And I think looking at this map, quite honestly, there's sort of a propensity of these to be concentrated in the eastern part of our state, as you can see there. So as a new radiation oncologist to the Outer Banks 10 years ago, we clearly had a big problem with cancer. Our hospital was already decade old with some services, but not a lot available locally. 95% of the cancers that I saw in the first few years of my practice were late stage, with the majority of those being stage 4 at presentation. Care was clearly disjointed, which led to suboptimal outcomes. And we felt that as a critical access hospital, instead of just focusing on our critical needs, which would be emergency room care and so forth, we decided cancer was a critical need in our community, and we decided to improve the cancer care through collaboration. So with the help of our administration, we looked at creating a cancer program using the model of the American College of Surgeons, with lung cancer at the center stage, and later with the hopes to become an accredited hospital. And clearly lung cancer was the elephant in the room for us, as it is for a lot of you in North Carolina. So I'm going to fast forward 10 to 20 years. So we're now accredited 3 times over as a hospital, and the only critical access hospital in North Carolina to do so. And so we get this data from the NC database regularly, which allows us to show our demographics. So if you look at the typical lung cancer patient rurally, and this is not just us, this is probably a typical picture that you would see in rural North Carolina, we have a large distribution of late stage cancers. And as you can see here in red, this is our hospital, which shows the majority are stage 3 and stage 4, and it compares to all the other hospitals in the country. And you can see that we have a disproportionate number of low stage and a largely disproportionate number of late stage. This to me was an eye-opener as a radiation oncologist. So some of the reasons for this, as you might imagine, we have a high percentage of smokers in the rural parts of our state. We have a high percentage of unscreened patients rurally. We have a lot of late stages, which account for some of these findings of higher mortality rates. We have high comorbidities, which make it difficult for patients to sometimes complete therapies or to be candidates for surgery. We have many barriers to care locally. And essentially every single patient with a potential for lung cancer has to leave our area to go somewhere to get a component of their care. So it's critically dependent on their ability to travel. So what's different? Now we have better access as rural providers. And every patient, again, has to leave our county, but the process is much better in terms of the timeliness to do so, facilitation of the process of their care from start to finish. And part of that for us is using a nurse navigator, which I'm sure every speaker here would acknowledge is a huge part of any program. And radiation oncology, I think, is a great example of where we've also improved access to better care. So this is the typical radiation oncology tool. This is a linear accelerator. This is much more available now rurally than it was in previous years. So 85 to 90% of lung cancer that we treat with radiation therapy is typically treated in rural North Carolina with this type of machine at some point in the patient's journey. Now, this is not available everywhere, and access still is a challenge for some areas. The typical treatment course is 5 days a week for 6+ weeks, which can still be a barrier in many locations. This machine has imaging and radiation delivery capability that can be done daily to better target the cancer and monitor the response to treatments as well. So using radiation oncology, again, as a marker of where we're doing better. So with improved access to better radiation oncology treatments rurally, we have more access to linear accelerators in our rural communities, such as our own, Dare County, and some of the other rural parts of North Carolina. We have better access to technological advances in radiotherapy planning, which can facilitate SBRT, which, of course, as you all know, is a huge technological breakthrough in the treatment of lung cancer. And this is now available in some community settings as well. We have better technology to deliver radiotherapy using image guidance, intensity modulation radiotherapy, a specific type of IMRT called VMAT. These are much more available in small communities. We also have better access to advice and collaboration with our peers in radiation oncology in various regions. And one of the big changes I think we see is that treatments are becoming shorter in duration because of this technology, and we're able to offer quicker treatments that can lessen the time needed to attend radiation therapy. So why does all this matter? Well, if you look at that same pattern of staging of cancer I just showed you, radiation therapy is now really an integral part of each one of these stages of lung cancer. Now, this is very different than it was 20 years ago. If you look at version 3 of the current 2023 NCCN guidelines, radiation therapy is specified in every stage of lung cancer from stage 1A through stage 4 as either definitive, consolidative, or palliative therapy. Now, this slide shows non-small cell carcinoma of the lung, but it would be the same for integration of radiotherapy into small cell. Interestingly, if you look at the guidelines, and I'm a big guidelines guy, and I check them essentially every day, 11 pages of the NCCN guidelines for lung cancer are dedicated to the principles of radiation therapy alone. So more aggressive local treatment now also becomes, I think, much more meaningful when we talk about the better systemic control of this disease. So with immunotherapy, we have a synergy between immunotherapy treatments and radiotherapy, which really allows, I think, the local benefit of radiotherapy to shine. We can now interpose shorter courses of radiation therapy, what we call hypofractionated treatment, which might be a few treatments to as many as maybe 15 to 20, which is much less than the classic time period of 6 to 7 weeks. And this allows, I think, integration with systemic therapy in a way that is best for the patient, which allows a more timely completion of therapy. This thereby removes some of the barriers to travel as well. We talk now about eradication of metastatic disease, which is something that was not in my generation of training, but we treat a lot of oligometastatic disease now with very aggressive radiotherapy doses, which are essentially ablative, akin to surgery. And with longer survivals, it's increasingly common to also have to consider the possibility of re-irradiating patients' lung cancers, either they're recurrent lung cancers or second or third new primaries. And this requires even better coordination of care and of technology. So some of the areas where we've made improvements, I kind of call less is more. These are some of the advances in radiation therapy care in our communities. We talk about sparing parts of the brain now that affect memory. That's called hippocampal sparing, preventative or prophylactic cranial radiation, which we do in small cell. This typically creates less toxicity. It involves less volume of radiation therapy and lower doses. We talk about using stereotactic therapy for brain mets almost uniformly now. It's rare that we offer whole brain radiotherapy, and we typically delay that to, again, minimize toxicity. We've got the use of memantine, which has been shown in randomized studies to also lessen toxicity when we radiate the brain. We've got the advent of respiratory gated therapy, which is now available in communities. This allows us to give very high doses of radiotherapy to very small volumes in the lung, to metastatic disease such as the adrenal gland. We can avoid PCI even in the setting of increased surveillance with our imaging these days. So that's an option that we offer patients. We avoid elective radiation now, which is very specific for lung cancer. We use PET imaging, which is much better, of course, for diagnostic purposes to highly target the volumes that we treat and to mitigate the toxicities by not radiating elective structures that are not involved by cancer. We also use IMRT, intensity modulated proton therapy, which we may hear about from our Charlotte speaker tonight. And of course, SBRT is really the greatest advancement probably in our field in the last 15 years, which lowers the toxicity and improves the local control for early stage lung cancers in particular. We also have a better understanding of tolerances to normal organs at risk, and that really has become more used in our interdisciplinary discussions, particularly with the academic institutions. So where can we do better? I like to focus on networking. And of course, this is a great network initiative. And I think when we talk about networking with rural America, and in particular rural North America, this is a great opportunity to discuss community and academic networking. So we have rural access to specialists through our partnerships. We're lucky to be a partner hospital with ECU Health in Greenville and also Chesapeake Regional Hospital in Virginia. So we're a little bit unique in our geography. It allows us to have two partnerships. And what we find is that every lung cancer patient has to go somewhere outside our small community. We don't have a pulmonologist to do biopsies. We don't have interventional radiologists to do CT-directed biopsies. So everyone has to go somewhere. And by adding a navigator, we, I think, really helped that tremendously. But by increasing our resources through these community partnerships and by coordinating those visits and by having patients enrolled in tumor boards specifically for lung cancer and having, multidisciplinary discussions with all of the speakers tonight, like we have with us, this has really helped us, I think, tremendously with the advances in lung cancer. So this is just a tip. This is sort of a graphic display of what we do in Eastern North Carolina for about the last 9 years, where we essentially have created a hub and spoke network with all of our community hospitals with the academic hub in Greenville. And this allows us to call in for tumor boards regularly. This allows us to have discussions with whatever providers we need and to really make sure that we have access to care, if not in person, at least virtually, for a lot of these patients' discussions. So we have found that by using this collaborative network, we really have begun to use NCCN guidelines much more routinely in the communities. And I think that's huge. Through our collaboration with an academic cancer program, we really truly have daily and weekly access to experts to care. And we find that allows better adherence to evidence-based guidelines for radiation oncology, just as an example. I'm going to show you a slide in a minute. Since 2014, as radiation oncologists in our county, we have been peer reviewing 100% of every curative cancer that we see in our community with the academic institution before primary therapy. So we talk about what volumes do we treat, what doses do we treat. We look at what contours do we actually include in what we define as the areas at risk and the areas that we're trying to avoid. And so all these measures are discussed before the beam is turned on for every single patient we see in Eastern North Carolina. And I think this has really resulted in better consistency in radiation treatments and better outcomes with appropriate referrals for services that we certainly cannot do. I can't do Gamma Knife in the Outer Banks. I can't do CyberKnife in the Outer Banks. I can't do intensity modulated proton therapy if that's appropriate. So we actually, through this referral system, have identified ways to offer what's appropriate locally and then refer patients who can get the services that are needed elsewhere. This shows what I call our really robust peer-to-peer review network. So we have essentially a program that started in 2014 with just a few of our regional providers. It's grown from 4 providers of radiation oncology to about 10 in our region. And we literally have presented every single case that's walked in our door that we treat for lung cancer as well as other cancers over the last essentially 10 years. And you can see the growth. So the blue shows all cancers that are discussed. This is a projected for this year. The orange shows our lung cancer, which typically is about 15 to 20% of our analytic load per year. But again, remember, every single case is being discussed prior to treatment planning, prior to radiation therapy delivery, and this truly helps with adherence to guidelines. So again, I think collaboration can be key to a rural success model. So, using coordination of specialty care for lung cancer between an academic cancer center, or centers of high volume, with smaller community cancers is just absolutely huge. This model of community academic networking really has allowed us to become the only critical access hospital in North Carolina to be accredited by the ACS. And again, that's because of the quality focus that's constantly being directed towards metrics that everybody considers a minimum. And again, this has helped us, I think, in one way that's hugely important that I'm going to show you in a second. It's really helped us reduce our mortality rates just over a short time of 20 years within our mostly rural geography, simply, I think, by increasing access. So this just shows, and this is linear, so I'm not going to tell you this is a linear progression, but it's an up and down model over the last 20 years. But if you look at where we started as a county in blue with lung cancer, we were definitely higher than the rest of the state. And over time, I think just by increasing access, we have now entered what I would call parity with the state of North Carolina. We're no longer contributing to disparity, but we're actually helping disparity through this model of collaboration. This is also interesting. If you look at what's happened over the last 20 years, and again, I think this gets back to that same model, this is the top 10% of lung cancer mortality counties in the state. So these states are bad performers, what I call outliers. And if you look at what's happened now, we've really helped eradicate the outliers in Eastern North Carolina. And we still have about the same percentage of rural outliers. It's just a different location. But clearly, being rural is still an issue that I think we need to think about at a system level and perhaps at a state level of how we can help these other counties minimize some of their disparities in these outcomes 20 years later. So interestingly, if you think about the population of our state, it sounds like a lot. 80% of our outliers are in rural counties. 68% of people in our state live in urban areas. If you think about that, it's even worse. So networks are huge. I think this partnership allows us to share resources that otherwise we would never have. This is especially evident in the time and frequency of specialized services like radiation therapy, where you have to come typically daily for weeks and weeks. And having access to specialists like those on this webinar today, I think is great because it really helps improve this model of collaboration. Our goal moving forward is to regionally consider what's called an integrated network of cancer accreditation. This would be done with our academic partner at ECU Health, and this would, I think, continue to allow us to address this regional barrier to care that we would hope to continue to improve. And collaboration, if you think about it, not just on a regional scale, but really as a state or at national levels, can really improve outcomes for lung cancer. As you guys know, we had a collaborative for the last 2 years looking at the Just Ask for tobacco cessation in our patient population. We have this year the COC collaborative, the Just Assist, where we try to help match patients that are smokers to resources that they can quit. And the current collaborative that I'm part of this year with the ACS is the Breaking Barriers, looking at ways perhaps we can remove some of the barriers to care using radiation oncology as a surrogate, but really as a marker of the cancer patient in general, and trying to make their journey smoother in their course of treatment. And that's all I have. Thank you.
Thank you so much, Dr. Shelton. And yeah, as a reminder, if you have questions for Dr. Shelton, please go ahead and drop them in the Q&A or just hold them and we can discuss them at the end. It is now my pleasure to introduce Dr. Oliver. Dr. Oliver, I will turn it over to you.
Hi, everybody. I'm sorry that I'm going to have to say next slide, but I wanted to talk with you guys. I'm a thoracic surgeon at ECU Health, and Dr. Shelton and I share a number of patients, and I'm very grateful for his work and for his participation in our tumor boards. I wanted to talk with the group about kind of updates in early stage lung cancer from a thoracic surgical perspective. Next slide. When we think about early stage lung cancer, there's really a clear cutoff. We think about stage 1, which is all T1 lesions without nodal or metastatic involvement. Stage 2 may have T1 lesions with N1 nodal involvement or T2 lesions, some with and some without nodal involvement, depending upon the T2 size and subgroup. And then T3 lesions will be a single stage 2B without nodal involvement with the most recent guidelines. Next slide. Here we go. And this is from the AJCC 8th edition of categories for early stage lung cancer. And I just put a little red outline around the little guys that let us know who's early stage and then what would be kind of late stage, similar to what Dr. Shelton was talking about. So today I'm not really going to go into 3A disease that gets neoadjuvant treatment and then followed by resection. It's a little bit of a deeper dive. I just wanted to kind of give you guys some updates on what we're doing for people with clearly early stage with either no nodes or higher node involvement, either based on clinical data or by biopsy. Next slide. So there are really 2 ways that we can handle this, and it's really all about local control. Dr. Shelton did a great summary of kind of how radiation therapy really touches lung cancer at every single stage. There's really no place where that is not either a mainstay of curative treatment for patients who cannot undergo resection or palliation for patients who are getting systemic therapy and helping with local control or consolidative treatment for systemic therapy. Surgical resection is a little bit different. Tell people it's a lot like being pregnant. Either you can do it or you can't. And if you don't get all of it, you really haven't done a patient a favor when we're talking about resection for cure, especially in early stage lung cancer. The gold standard right now is really lobectomy. One thing that's not included on my slides that I will talk about here briefly at the end is there are two recent studies, one that came out of Japan in 2022, and then the most recent study was, both of them are randomized controlled trials. One is a phase 3 trial out of Japan looking at segmentectomy versus lobectomy, and then a US trial, which is also a phase 3 randomized controlled trial looking at segmentectomy, including non-anatomic segmentectomy and lobectomy in head-to-head randomized fashion to see if there's a difference in survival, local recurrence, and disease-free interval. But we'll get to that because it's actually kind of cool, and I want to make sure that we can kind of talk about that. In general, these days, when I first started in med school, everybody was getting a thoracotomy in order to get their cancer out. Now, at least here at ECU Health, our group is pretty much 98% of all of our resections are done minimally invasively. That either means with a thoracoscope, which is video-assisted thoracoscopic surgery, or with a robot, which is basically the same thing, just more expensive. The great thing about surgery is that it allows for more extensive mediastinal lymph node sampling, which allows us to really verify whether or not our clinical stage really is reflected with a true pathologic stage. So we really know where we're starting our treatment from. The other local control avenue is actually touched on by Dr. Shelton, and that's stereotactic body radiation therapy. In the short term, it seems like there are equivalent outcomes actually between lobectomy, segmentectomy, and stereotactic body radiation therapy, mostly because of its precision. And in early stage cancers, as Dr. Shelton talked about, it really can be seen as an equally efficacious ablative therapy. Minimal morbidity with the most recent iterations of the technology, and really excellent local control, even up to 3 years. Next slide. So this is one study that I had found actually a little bit a while ago, which basically was done by David Odell, and basically did a head-to-head review of early stage lung cancer with SBRT versus surgery. And what they noticed was actually the folks who fell into the SBRT group, and this was a retrospective study, this was not a prospective study, but they found that the patients who underwent SBRT were more likely to be elderly, to have a lower T stage, and to be African American, or to be listed as having a Black race. So that may also include non-white Hispanics. Surgery associated with the higher median survival, but that's probably related somewhat to selection bias. More fit people are usually given the option of surgery, where people with more comorbidities are more likely to be recommended for SBRT. And that surgery benefit actually persisted after Cox regression analysis of the two subgroups, with a hazard ratio of 1.69, which was statistically significant. Next slide. And then the other big question that comes up, if you have a patient who you're either not sure if they can go for surgery, or you're trying to recommend them for SBRT, is really the question of local recurrence. And in the early stages of SBRT, I think that this was a much more meaningful question. I think with the current iterations of technology, it really has approached an ablative quality and durability in terms of local recurrence, mostly because the intensity of the energy that's able to be delivered, I think, is a higher quality and really hasn't borne out in some of the most recent studies. The other is that the tightness of the field and the contours has really allowed for, even if you have subjacent local recurrence, it's similar to if you had a staple line recurrence for perhaps somebody who had a wedge resection or a non-anatomic segmentectomy. It was in this study, it was associated with increased local recurrence and decreased overall survival, as well as increased regional nodal recurrence. Now, I will say in defense of SBRT, they're not trying to get to any of the lymph nodes. So you're really not doing anything for the natural history of the disease because you really don't have any nodal sampling, which is what oftentimes makes surgical resection something that's preferable for a patient who can undergo that form of therapy. Next slide. So before I get to this slide, you guys can look at it and read it, but I do want to actually talk about what I think is the most exciting thing which has come out, which is these last two trials, both in Japan and here in the United States. Many thoracic surgeons have really wanted to ask the question, is there truly a difference, or are we just going back to our original data from the 80s and early 90s and saying lobectomy is a gold standard because it's the widest resection that you're going to get anatomically, and therefore you're going to get a very durable clinical response and really the best overall survival. But is it really the best surgery for every patient, especially with early stage lung cancer? These two studies both looked at early stage 1 lung cancers that were less than 2 centimeters. Many of them, I think the Japanese study was peripheral. The one in the United States did not indicate location, but it could not be a hilar or central tumor because that would actually require lobectomy. Both studies required no clinical evidence of nodal involvement and an extensive lymph node dissection that confirmed no nodal involvement. And in those patients, both studies actually found that the U.S. study, which was in the New England Journal of Medicine, which was led by Dr. Al-Torki, showed a non-inferiority for lesions that were less than 2 centimeters and node negative. And they have a similar overall survival. So it confirmed what we call a non-inferiority of segmentectomy to lobectomy. And hidden within that, and soon to come out, is their subgroup analysis looking at non-anatomic segmentectomy versus anatomic segmentectomy, because there are many patients that get generous wedge resections in order to preserve lung function. And we wanted to see whether or not those would behave like SBRT or would they behave more like a segmentectomy with an extensive lymph node dissection. The Japanese group actually found that lobectomy was equivalent to segmentectomy in terms of overall survival, but there was a slightly higher local recurrence rate with the segmentectomy in comparison to the lobectomy. And so the reason why I find that really interesting is that it's really the first time where sublobar resection has really come to the fore. And between, just as Dr. Shelton was saying, there's been some advances in technology for us to use in the operating room that allow us to be much more precise about how we define anatomy and how we can address anatomy, not just in terms of minimally invasive approach, but once we were in the operating room, technologies that allow us to identify venous drainage, true segmental anatomic landmarks using ICG and other little tricks of the trade that can allow us to preserve much more lung tissue than previously we thought we could and still perform an acceptable oncologic resection. So that's really probably the biggest leap forward for us. And it actually allows a whole new segment of patients who previously, if they couldn't get a lobectomy, we weren't really sure whether or not we were helping them with surgical resection. And now we've been able to prove that there's a subset of patients for whom, if we tailor the operation and we pick our patients well, we can get them the same effect that the patients who are early stage that could undergo lobectomy with a standard lymph node dissection, that we can get them the same survival and same local control. So that's a huge step forward academically for us to prove what we've done in practice and maybe help many more people with early stage lung cancer. SBRT is kind of our ally in this. And the increase in its use has allowed many patients who have early stage cancer to get complete treatment. And as Dr. Shelton was saying, especially here in Eastern North Carolina, access is everything. And if we can get people treatment closer to home and have them complete treatment closer to home, if we can give them equivalent outcomes and get them back to their homes as quickly as possible, we not only improve their survival, but we also improve the health of the communities that we serve. Surgery will remain the gold standard, and is still associated with less local and regional recurrence and improved overall survival. But I think that that gap is narrowing as technology moves forward. And then, as I was just saying, with our most recent data that I reviewed with you guys, that there's also perhaps even less morbid surgical intervention that allows us to have improved precision. And unfortunately, we as surgeons don't really move as quickly as the radiation oncologists. We're kind of oafs when it comes to moving forward. But I'm excited to see that we are beginning to ride the crest of that wave of movement forward with our oncology colleagues, with incorporating neoadjuvant therapies, not just for other cancers, but specifically in lung cancer, and then also being able to take a page from the notes of our radiation colleagues and really trying to be more precise with our surgical interventions and improve outcomes. There'll still be ongoing research, as I was saying. Keep your ears kind of open for this secondary subgroup analysis. And when you're thinking about a patient and trying to decide whether or not somebody's a surgical candidate, err on the side of sending them to a surgeon to be evaluated. You may be surprised at who we can support through an invasive surgery, how well they can function afterwards, and how well they can have a disease-free survival. We're able to care for our more fragile patients much better in surgery than we could even 10 years ago. And the scope for cure has broadened as we bring in other disciplines to help us do surgery better. So thank you for your time. And I think that's my last slide.
Thank you, Dr. Oliver. I will now turn it over to Dr. Hagstrom.
Thank you. Let me make sure I can do this part of this correctly. All right, can you guys see my slides?
Yes.
Great. I'm Dan Hagstrom. I'm one of the thoracic medical oncologists that works for Levine Cancer Institute. Thank you for the opportunity to present this information. And tonight we'll be talking about small cell lung cancer, which was what the task provided to me. I believe one of the other presenters will be talking a little bit about the advances in non-small cell and specific targeted therapy. So this is more small cell. And this has not been a very big year in small cell lung cancer. So some of these figures may be reminiscent. So our objectives, we're going to talk a little bit about the Caspian data, which was updated in the fall of this year. We'll talk about lurbinectedin, which is a newer agent that is making its way into the refractory space, as well as some abstracts from ASCO this year. So framing the question, in the United States, be more than 230,000 new lung cancers and over 130,000 deaths this year. Within our own state, 24 people will be diagnosed and 13 people will die of lung cancer today. And although historically speaking, this is a smoking-related illness, approximately 60 to 65% of the patients that are newly diagnosed have either never smoked or have quit smoking. So those are our patients that we're seeing in our clinics now. Small cell lung cancer accounts for 10 to 15% of newly diagnosed lung cancers worldwide, with over 30,000 new cases expected this year in the United States. And forward to the time of diagnosis, 80% of these patients have advanced or incurable disease. The 5-year survival rate for this cancer is dismal, with less than 5% of the patients achieving that milestone. And although we have identified molecular mutations in PPP3, retinoblastoma gene, and the MYC pathway, there's been no targetable genetic alterations to date. This type of cancer shrinks very quickly with treatment with radiation or chemotherapy, but relapse remains the rule rather than the exception. Without a documented driver mutation, survival and treatment for this disease really did not move very much, or the needle didn't move very much until 2018. So immunotherapy, and specifically checkpoint inhibition, has dramatically altered the treatment of lung cancer patients. Unlike non-small cell lung cancer, the PD-L1 expression in small cell lung cancer varies greatly and is not predictive of treatment responses. And despite this variance, the introduction of durvalumab as well as atezolizumab have yielded significant improvements in the overall survival for small cell patients. So first, we'll talk about durvalumab and the Caspian data set. Caspian is a randomized phase 3 trial that compared standard toposided platinum chemotherapy with durvalumab or durvalumab and tremelimumab. Tremelimumab is a CTLA-4 inhibitor, whereas durvalumab is a PD-L1 antibody. So immunotherapy, both different, but they are oftentimes used in together to fight different types of cancer. So in this study, there were 805 patients. There were 268 patients that were allocated to the 2 treatment arms that contained the immunotherapy, where 269 patients were in the control group. The control group got 4 to 6 cycles of platinum etoposide chemotherapy, then observation, whereas the immunotherapy containing arms both received durvalumab every 4 weeks as a maintenance medication on completion of 4 cycles of combination therapy with chemotherapy. The durvalumab was continued indefinitely until there was progressive disease. This was initially published in 2019. It was updated this past fall at ESMO with some interesting long-term data. So the 24-month PFS was 11% in the durvalumab and immunotherapy, or excuse me, chemotherapy arms versus 2.9% only in the chemotherapy arms. Overall survival was 12.9 months versus 10.5 that favored their durvalumab containing arm. Interestingly, with the 4-drug regimen, 2 immunotherapies, and 2 chemotherapy, the overall survival was 10.4 months, but that was not a statistically significant difference between the control group. At 36 months, 3 years, which is what the important part of this data set was, 17.6% overall survival in the durvalumab containing arm versus 15.3% in the 4-drug arm versus 5.8% in the chemotherapy alone arm. The objective response rates, again, 68%, 58% favoring durvalumab. And some of the responses were actually were durable in the durvalumab arms at 2 years, 13% versus 3.9%, which is relatively unheard of for small cell lung cancer. Here's a graphic representation of what I just mentioned. Median overall survival was 12.9 versus 10.5 months, with a 36-month overall survival of 17.6% versus 5.8%. The figure on the right is the hazard ratio plot, again, favoring in all patient characteristics the provision of durvalumab with the chemotherapy. So one of the more interesting parts about this study in the ESMO data was there were 46 patients at 3 years that were still on therapy, which again is unheard of for small cell lung cancer. And in exploring these patient population, the patients had a greater exposure to chemotherapy and immunotherapy in terms of number of cycles given. They had higher rates of cisplatin use, and they had better response rates compared to the intention treat population within their own treatment arms. In the initial publication in 2019, there was a question of a specific genotype that might allow for a better response for dual agent immunotherapy responses. That was refuted in this data set. However, in bold, at 36 months, patients were 3 times more likely to be alive if they had been treated with durvalumab and chemotherapy versus chemotherapy alone. I put table 1 in here, which is a very fascinating table to me. In this table, there at 3 years or more than 3 years worth of data points and evaluation, 9% of the people that got durvalumab and 8% of the people that got the durvalumab and tremelimumab arms or treatments were still alive. So alive at 3 years is a remarkable thing for small cell and extensive stage disease. And I think it bears some important evaluation for these patients. What separates these patients? Why are they different? How can we find this potential set of patients and those that we see for small cell lung cancer? Because they are out there based on these statistics. I put this slide in from a recent talk. I think this is kind of an important thing, and I won't try not to go over. This is a discussion of financial toxicity. So, and the figure on the far left is a publication from Nature magazine in March of this year, which documents that 15% of the global economic costs of all cancers are related to tracheal, bronchial, and lung cancers. And you can see in the middle figure that the cost of care is much higher for patients as they get into more or different systemic treatments like chemotherapy, not systemic, but local therapies like radiation, as well as immunotherapy. And this harkens back to the prior, Dr. Patel's talked about screening, in the sense that we're not catching people earlier enough to where those things can be avoided. And these costs are really, really high. This last paper was a publication, an abstract from one of our fellows at Living Cancer, who published an evaluation of the comparison of atezolizumab, which is also approved by the FDA for small cell via IMpower 133, as well as durvalumab, which is the agent we just spoke about from the Caspian data set. Just comparing the cost of these two agents, as well as the acquisition of potential bad debt. And hopefully some of my colleagues that are on from AstraZeneca are not present, but like the cost of provision of a biologically similar agent costs patients on average nearly $2,000 more. And so we're in an age where we need to be more concerned about the cost of things. At Living Cancer, we have a financial toxicity tumor board that we now run and look at different cases for different cancers and evaluate the cost of the things that we do for patients. Let's talk a little bit about lurbinectedin. The median survival of patients with relapsed small cell is relatively dismal. It ranges from 2 to 6 months, and it historically leaves patients with very few active options. The response rates to second-line chemotherapy range from 20 to 30% in platinum-sensitive or chemosensitive patients versus 15% in patients that are platinum-resistant. And although agents have shown activity in small studies, topotecan historically has been the only drug approved for second-line treatment for patients with a chemotherapy-free interval longer than 60 days. The figure on the right is from the NCCN guidelines, and I'll be talking about lurbinectedin in a couple of slides here. So lurbinectedin is an alkylating agent. It's similar in structure to a marine-derived agent, ectinicidin, which is trabectedin. And it has an anti-cancer agent that is found in the extracts of the tunicate ectinicidin turbinata. So this agent has broad anti-tumor activity. It pairs transcription factors in DNA repair pathways. It creates double-stranded DNA breaks, leading to cell death, and it prevents human monocyte activity and macrophage infiltration. This was published in 2020, and it continues to represent the first new option for patients available to patients with relapsed extensive small cell lung cancer. I didn't mention this earlier, but unfortunately, immunotherapy trials for patients that had failed chemotherapy before have subsequently failed in small cell lung cancer to show improvement in survival. So at this point, immunotherapy needs to be given up front, so you're still struggling with what to do when patients relapse. So this study, B005, was a phase 2 study. Patients that were allowed in with small cell lung cancer that did not have brain mets, who had previously progressed on platinum-based therapy. There were 105 patients, and it was finished enrollment in 2019. These were standard prognostic portions of the patients that were in this study and listed here. I'm sorry for it's a bit small to review. Some of the standard things for small cell, 70% had extensive stage with 75% more than 3 sites of disease. Elevated LDH is a known poor prognostic indicator for small cell, and 45% of the patients had elevated LDH. Over 60% of the patients had ECOG 1 or 2 status, with 8% of those being ECOG 2. And I highlighted this important fact: 57% of these patients were platinum sensitive versus 43% resistant, meaning there are patients that had prior responded to therapy, which is hopefully a good indication of what might be to come. So in this study, the overall response rates were 33% with a disease control rate, which is partial responses versus added with stable disease, of 68.6%. The median duration of response was 5.3 months, with 43% of the patients' responses were prolonged and exceeded 6 months, which again for small cell is a very good number. The median overall survival was 9.3 with a PFS of 3.5 months compared to topotecan. Topotecan's literature was published in 1999, and that drug was approved by the FDA because it actually improved symptoms, not based on statistics of improvement from survival. So the overall survival extension of 3 months was a significant difference compared to what was previously believed to be standard. And in the clinic, when this medicine is utilized, it has some degree of bone marrow toxicity, mostly neutropenia and leukopenias. However, most were tolerable. There were no treatment-related deaths in this study. And eventually, 22% of the patients went on to get growth factor support, which can be approved depending on the patient's counts and how they tolerate the medicine itself. And there have been further studies with this agent. In the earlier stages, this drug has been shown to have synergism with other chemo drugs as well as potentially biologic agents. So it makes sense then to study them with other agents as well. The Atlantis study that was published in 2021 was a negative study in terms of efficacy, comparing combination lurbinectedin with doxorubicin versus topotecan or CAV, which is an older combination regimen for small cell. Although it was negative, it also showed that this drug was continued to be well tolerated and when used in combination. This is the schema of IM Forte, which is a review of lurbinectedin addition to maintenance atezolizumab for patients who have received response from extensive stage small cell. So patients will get randomized after they receive their chemotherapy to get either maintenance atezolizumab or maintenance atezolizumab plus lurbinectedin. And I think we're all going to be eager to hear that. And the Lagoon study is a study that's looking at lurbinectedin versus lurbinectedin in irinotecan and salvage. Finally, I'm running out of time, so I'll go quick. Oops, sorry about that. My EMR popped up. Small cell abstracts from 2023. Again, this was a relatively short or small list of things because this wasn't a big year in small cell lung cancer. The things that I found interesting in the ASCO meeting this year, abstract 8512 was a phase 2 comparison of high dose twice daily radiation to standard dose twice daily radiation for limited stage small cell lung cancer. Again, a nicely populated study of 170 patients. The overall survival improvement in the high dose arm was kind of eye-opening, 43.6 months versus 22.5 months, with not a giant change in toxicity. In my own clinical practice, having twice daily radiation therapy, very, very, very few patients can come for twice daily radiation for small cells. So that is something that I don't see that regularly, even at a large center in Metro Charlotte. But that is going to bear out some, or needs to be further evaluated or flushed out by more study. The Trident study was a single-arm phase 2 study that used a known improved PARP inhibitor with durvalumab as a maintenance. The overall survival had not been reached by the time of the publication, which is encouraging. And 8576 was a classification of platinum sensitivity versus refractory patients or refractory status in the age of immunotherapy. The classic hallmark for responsiveness for therapy, infusional therapy, is 90 days. However, in this retrospective analysis, patients were evaluated and reviewed at their time of progression. And there was a question in the age of immunotherapy with frontline therapy if 75 days was a better marker for better survival statistics. So that's a very interesting idea. So in conclusion, the updated Caspian data set confirmed a 3-year overall survival improvement with provision of durvalumab and standard frontline etoposide platinum chemotherapy. It continues to support IO and chemotherapy as the first-line standard of care. Lurbinectedin is an active agent in second-line salvage. It does have synergism, so I would expect some combination studies to be ongoing and reviewed. There remains a debate whether or not twice daily radiation and at what dose for limited stage small cell lung cancer, and that certainly needs to be further evaluated and reviewed. And whether or not 75 days might be a better day or a label for a patient who has responded or not responded to frontline therapy. All right, that's all I have. So I guess we'll hold questions to the end.
Great. Thank you so much, Dr. Hagstrom. And now I will turn it over to Dr. Patel.
Thank you, and thanks for everybody for hanging out with us this evening. So I'm a thoracic medical oncologist at the University of North Carolina in Chapel Hill, and I'm going to be talking today about biomarker testing in lung cancer and how it touches on our treatment for patients. So just a brief outline, I'll be talking about what biomarkers are important to look for in our patients with lung cancer. These include genetic changes in the cancer, but also increasingly as we use immunotherapy in our patients, trying to understand the microenvironment of the cancer and how it interacts with the immune system through assays such as PD-L1 testing. What approaches we have to looking for these biomarkers, what should we be testing for, and why is biomarker testing important, and why we want it to be done comprehensively for our patients, especially advanced patients. So to walk us through, I wanted to start with a brief case, a patient that's a 47-year-old former 5-pack-year smoker who presents to primary care with a few months of cough and has had a chest x-ray that shows a possible lung mass. They go on to have additional imaging done, which unfortunately finds a lung cancer with a biopsy of a liver lesion showing a lung adenocarcinoma. So this patient is worked up and then sent to a medical oncologist for thinking about treatment options. What additional information are we going to need to really decide on what's the best treatment option for this patient, with the goal of individualizing the treatment for the patient? We know, unfortunately, that they have stage 4 disease, given the spread to bone and liver, but there's additional information that will be critical for guiding their treatment approach. So before the advent of biomarker testing for lung cancer, we had what now seems to be a relatively crude approach where we just looked at the cancers underneath a microscope and classified them as non-small cell cancers, which were typically further subdivided into adenocarcinomas or squamous cancers, and then small cell lung cancers, as Dr. Hadstrom was just discussing recently. And we've learned from doing profiling and understanding the biology of these cancers through genomic profiling, as well as looking at the microenvironment of these cancers, that while they may look somewhat similar under the microscope, from a molecular level, they're actually quite distinct. And the understanding of the molecular changes, as well as the interaction of the cancer with the microenvironment, is really critical for picking what the right treatment is for patients. And so that's what really biomarker testing is designed to do, is to take what is a little bit more of a crude diagnosis of a cancer underneath a microscope, do additional profiling through genetic analysis, as well as additional protein analyses, such as immunohistochemistry, to really understand better the biology in any given patient, and then select a therapy that's more targeted and precise for that patient. So initially, that in advanced lung cancer, we focused on looking at patients with non-squamous histology, and we found that there were a number of genetic changes that we could identify, which we have now targeted medications for. So this is sort of an updated pie chart of the potential genomic driver alterations that we can see in patients with non-squamous histology, and the different agents that are available to target these alterations, starting with the prototype of genomic targeting, which is EGFR mutations, to some of our more recent agents, including targeting KRAS, which is one of the most common driver alterations that we see in non-small cell lung cancer. So I won't be touching on all of these treatments, but this pie chart really highlights the number of different options that we have for patients and why profiling for these alterations can be important given the treatment options that are associated with them. So what are the approaches that we have to identify some of these biomarkers? So most of our initial testing is often based on looking at tissue biomarkers. And so that can include things like immunohistochemistry, where we're staining a tissue section to look at certain proteins. Some of the alterations that we initially were finding in lung cancers, we would identify by procedures such as FISH and PCR. But what we're really moving to more is now using more advanced sequencing approaches called next generation sequencing of either DNA or now increasingly more the RNA, which is the message that's generated by DNA, to look at what the genomic alterations are in the cancer in a broad fashion. So what is next generation sequencing, and why maybe this be a more advantageous approach for looking at biomarker testing? So comparing next generation sequencing to our previous methods, which were PCRs, which is where you're looking at more single genes or even just portions of single genes, Next generation sequencing approaches are higher throughput assays. They allow us to look concurrently at a number of different genes. And as you can recall from that pie chart, we now have a number of different alterations that are important in knowing for treating patients with advanced lung cancer. So the advantages of these approaches include that they're really more comprehensive and that you can use one tissue specimen to look at a broad panel of genes rather than looking at single genes or hotspots where you may have more limited information that you get. There are, of course, some challenges with each approaches because of the broader number of genes that are being looked at. The interpretation and performing these assays often has to be done in specialized labs that need to be sent out tests. That increases the time for getting these results back. Now, these are more tissue-based approaches that we were talking about initially, where we're looking at taking a tissue sample that's identified by a biopsy and performing these immunohistochemical or genetic tests. But sometimes we see patients in the clinic where it's difficult to get sufficient sample to be able to run these tissue-based analyses. And that's where performing what we call liquid biopsies or circulating tumor DNA assays has been a significant improvement in helping us still identify some of these genomic alterations without potentially having to put patients through additional biopsies to get tissue to be able to run these tests. So these liquid biopsies are based on taking a peripheral blood sample, so regular blood draw, like we would do for looking at a CBC or CMP. And they take that blood and try to isolate what we call circulating tumor DNA, which is the fraction of DNA from the tumor that's circulating in the blood. These assays, similar to looking at it in tissue specimens, initially started with single gene assays, including the COBAS EGFR test, which was one of the first liquid biopsies that we had, to moving into now using next generation sequencing approaches where we can again look at a broader number of genes simultaneously to try to identify all the potentially targetable alterations that may be present in a patient's cancer. So as we think about using these assays, like I mentioned, there are certainly advantages in patients that have limited tissue specimens for analysis, but there's some important caveats to think about when you're interpreting these tests. One is that certainly even in patients with stage 4 lung cancer, so metastatic disease, you can get false negatives, meaning that you don't detect any alterations in the blood. And that may not reflect the fact that there are not genomic alterations in the patient's cancer, but that there is not sufficient tumor burden or different shedding properties of the tumor that make it difficult to detect in the blood. And this is often the case in patients that have limited extrathoracic disease burden. These tests also are not 100% specific to genetic changes that are present in the cancer. So you may detect alterations that are non-lung cancer derived. So a common thing that can be seen is things such as clonal hematopoiesis, which are genetic changes that happen in the bone marrow, especially as patients age. Sometimes detection of gene fusion can be a little more limited through these assays. And again, because they're looking at genetic changes, they don't allow us to identify histologic changes that can occur in patients as they're undergoing treatment. So just some important caveats to consider in interpreting these results. But this is a nice framework that's been provided by the International Association for the Study of Lung Cancer on how these liquid biopsies can be incorporated into our practice. And different groups have different approaches to it. But one way that has been suggested is that sort of sequential approach, where if you have tissue that's adequate for doing genomic profiling, you send the tissue first, and then cell-free DNA can be used to complement in cases of incomplete genotyping. In some places, concurrent or testing is used. In some places, plasma-first approaches are used. But in general, what we found is that these liquid biopsy approaches can complement and help us complete comprehensive profiling for patients, especially in patients that are started on treatment and then may have progression of their cancer. Can also be particularly helpful to identify resistance pathways. Now, these genomic pathways are for helping us to identify targetable alterations that are able to select for oral therapies often. What are the biomarkers that we're going to use to select for immune checkpoint blockade, which is another main part of our treatment for advanced lung cancer? So currently in lung cancer, the main biomarker that we use clinically is PD-L1 expression. And PD-L1 is a bit of an indirect biomarker that we can look at to see whether a cancer has an immune activity against it that's been suppressed by these suppressive checkpoints. So PD-L1 can be expressed on tumor cells, which is shown in the images on the left here, or it can also be expressed in immune cells in the microenvironment. And that PD-L1 is thought to decrease the activity of some of the T cells, which are important immune cells in an anti-tumor immune response. In lung cancer, the main approach that we use is the tumor proportion score, which specifically looks at the PD-L1 expression in the tumor cells. And how that compares in the tumor versus the microenvironment. But what we've learned is that, this isn't a perfect biomarker, unfortunately, because it's only one of multiple ways that the immune system can be downregulated or prevented from being activated against the cancer. So this gives us a sense of the likelihood of response, but it doesn't correlate directly. Another biomarker that's been used for selecting patients for immune checkpoint, or at least investigated, is something called tumor mutational burden. So this is a genomic biomarker where we're looking at the overall number of genetic changes that a patient has in their cancer relative to what we consider a normal genotype. And these genomic alterations in the cancer sort of generate altered proteins that can be signals for the immune system. This isn't something that we use as commonly, but it has been correlated in other studies. It's just been difficult to derive a very specific cutoff point for TMB in lung cancer for selecting patients for immune checkpoint. So why is identifying and performing comprehensive testing really important? Well, as we saw in that pie chart at the beginning of the talk, there are a number of alterations that we now can target with our medicines, and having that genetic information allows us to select the right therapy for their patients. And this is just a little bit of a historical perspective. This is x-rays that were taken from a patient with an EGFR mutated lung cancer who was treated with a targeted therapy. And x-rays are a relatively crude way for us to look at cancer burden, but what you can see in this patient is that even within a few days of starting on this targeted therapy, that you see a really rapid response. And that's the benefit of finding these alterations, is that you're really finding something that you have a directed therapy to target that correlates to the biology of the cancer. And this has been correlated also with improved outcomes in patients. So this is data from the Lung Cancer Mutation Consortium, which was a large number of sites that looked at patients that had genomic profiling done, how comprehensive that genomic profiling was, and then whether they got matched to targeted therapy based off of that genomic profile. What you can see is patients that had a driver mutation and got targeted therapy did better than those who didn't have a driver alteration, and those who had a driver alteration but didn't get targeted therapy. And there's been more recent data that having this information early prior to starting patients on first-line therapy is also really important to correlate with outcomes. So patients that had testing available at their first visit seem to do better than patients that didn't have that testing. So if we return to our patient's case, we would want to have PD-L1 testing as well as genomic profiling, knowing that this is an advanced lung adenocarcinoma. So this patient has a PD-L1 score of 80%, and then on genomic profiling is found to have a RET fusion. We know they have stage 4 disease. So how do we use this information? Now, this can be sometimes conflicting. You have a high PD-L1 score as well as a genomic biomarker. Which of these two biomarkers do you go with, which you run with? What we've learned is that in patients with most targetable or driver alterations, they tend not to respond as well to immune checkpoint blockade. And so having that RET fusion, that's going to be the important biomarker for selecting therapy. And it's actually important to potentially avoid giving them checkpoint blockade up front. And I'll talk about that briefly on the next slide. And that's because we've seen that in patients, in studies with patients that had EGFR alterations as well as ALK alterations, the sequencing of treatment can be important because we've seen immune-related adverse events increase in patients that get checkpoint blockade first, followed by a targeted alteration. And so having that genomic profiling early before potentially exposing patients to immune checkpoint is important in selecting the right treatment. And so just briefly rounding out for this patient, RET fusions are one of the common alterations that have recently been identified. There's relatively few percentage of patients that have them, but in lung cancer, we typically see fusion events. Common partners are KIF5B. And there are two agents that have now been approved for patients with RET fusions. The first, selpercatinib, we see the data here published from the Libretto study in the New England Journal a couple of years ago. Very high response rate, both in treatment-naive patients as well as patients that had received prior chemotherapy. And encouragingly, we see patients having intracranial responses. Similarly, a second agent that targets RET, pralsetinib, in the ARROW study showing high response rates, both in treatment-naive and prior platinum-treated patients. So these waterfall plots are some of the promise of targeted therapy and why we want to have this information for our patients before we select treatment. And then I'll briefly touch on one of the newer alterations that we now have targeted medications for in advanced lung cancer, and that's targeting KRAS, which is one of the more common genomic alterations that we see in lung cancer. Specifically, we have agents that now target the G12C genomic change, which is present in about 12 or 13% of lung adenocarcinomas. KRAS was thought to be one of our long undruggable targets until these agents came into practice. And so these drugs target specifically the G12C binding to the switch pocket, and there are two agents that are approved. One is sotorasib, which we saw from the CodeBreak study showing response rates in the 30 to 40% range, stable disease on another significant fraction. And then similarly, adagrasib, which was looked at in the CRYSTAL study. And these are both approved now in the post-chemo immunotherapy setting. So to summarize, in 2023, we have a number of different genomic biomarkers that can help us select therapy for advanced non-small cell lung cancer, EGFR, ALK, ROS1, BRAF, NTRK, RET, and MET in the first line setting, and then KRAS and HER2, which have treatment options in the second line setting. And because of these number of alterations that we have and the promise of these therapies, it's really important to have all of the genomic information before making a treatment decision. I'll summarize here in terms of the genomic alterations that we can look at. And then for immune checkpoint blockade, really our mainstay biomarker is PD-L1 immunohistochemistry, which is used to select for checkpoint blockade. But looking to the future, there are some important considerations coming down the pike. As we start moving some of these agents as well as immunotherapy into earlier stage patients, particularly neoadjuvantly, important questions include what testing should we be doing in earlier stage patients? Should that be limited to EGFR and ALK or more comprehensive NGS testing? How can we really accelerate the availability of these results? And I think partnering with colleagues in interventional radiology, interventional pulmonary, other disciplines in surgery that are doing the initial biopsies on patients to making sure that this testing is getting sent off early is important. And I think coming down the pike are probably going to be more multi-omic approaches to immune checkpoint blockade, where we're not just looking at PD-L1, but other approaches that give us a better sense of whether there has been an immune response against the cancer to select patients for these therapies, as well as dynamic responses to checkpoint blockade, such as looking at ctDNA dynamics early in treatment and how they correlate with long-term disease control. So hopefully that will allow us even more precision as we select therapies for our patients.